Institute under the Ministry of Health. And welcome to Thailand.
We prepared a whole day side meeting for everyone, but we know that there's a lot of competition. There are a lot of nice side meetings there. I might attend some of them myself later on. But we appreciate your decision to come to this morning meeting. The morning meeting is more for high-level strategic decision makers and also the implementers of e-health programs at national level. The afternoon are operational discussions about national e-health programs and sharing of at least 2 countries on how they are, what lessons they have learned and what best practices they have accumulated over the years for their national e-health programs. So for the morning, of course, first of all, I'd like to thank Dr. Bunchay and Win Min for coordinating this side meeting. This started last year when we were together at the AHIN third general meeting hosted and organized by WHO and ADB in Manila. And in that meeting, Dr. Bunchay suggested that it might be a good opportunity to be part also of the Prince Mahidol Conference, Awards Conference in Thailand and share the important agreements and output that we called in our meeting in Manila. There were 2 meetings in Manila. The first part was the conference on measuring and achieving universal health coverage with ICT, followed by the AHIN third general meeting. And we will consider this 3 hours to be a encapsulated version of our 4-day meeting in Manila, where we will try to share with you the salient and important points that we learned from those 4 days in Manila, and some other insights that came on that we learned in between those 4 days up to now. To give our opening remarks and the overview of National Health Information Systems Development, we have now, we are honored to have with us the advisor to the Deputy Minister of Public Health and the Director of the Thai Health Information Standards Development Center to welcome us. May I call on Dr. Tiem Ung Sachon. A big hand for Dr. Tiem.
Good morning, everyone, and thank you for your coming today to this Asia eHealth Information Network AHIN side meeting at Prince Mahidol Award Conference. On behalf of Dr. Sonsak Chinarat, Deputy Minister of Public Health Thailand, it's my privilege to welcome you to this meeting. I wish to take this opportunity to welcome His Excellency Secretary Mr. Shanta Cheta from Ministry of Health and Population Nepal, and Her Excellency Deputy Minister Professor Teng The from Ministry of Health Myanmar. This meeting brings together participants from 13 countries, and I'm grateful to see the Mr. representative from development partner, academics, and ICT person here today, and warm welcome to you all. Distinguished participants, there are so many results I can put across to indicate how important e-health and universal health coverage and ICT have been to our country. E-health is a priority and a common goal for all of us because it means to provide better health care. With respect to universal health coverage, as stated by Mr. Dr. Makarachan, is the single most powerful concept that public health has to offer. It's inclusive, unified service, and develop them in a comprehensive and integrated way based on primary health care. The significance of e-health and the role of ICT in achieving UHC are well recognized by several international networks such as WHO, ADB, UHCICT, Knowledge, UHCICT, UCED, UNED. Ladies and gentlemen, we already know that integrated health information system is one of essential building blocks the effective natural health system. To achieve universal health coverage, effective natural health information system and e-health are needed. And one of the very important components of natural health information system and e-health is natural HIS and e-health capacity building. I wish to acknowledge the support for e-health in capacity building, such as the training program, such as the SL7, Enterprise Architecture, COVID-5 Foundation in the past year. We have made a commitment to put in place a national health strategy, and we all share the common interest about achieving UHC through ICT. I strongly believe that experience from one country can be highly informative for the other. Trying to do the mission, and I hope you will all benefit from this meeting. Thailand National Health Information System and e-health, thought not perfect, contribute UHC achievement. The National System Identification System, the implementation of standard data set for health insurance, the implement of ICT and DRG, and the high penetration of computer and ICT at all levels of health provider are sample factors that help the country building health information system that support the implementation of natural universal health coverage. However, our country's recent research on e-health show that Thailand is still far behind in having effective health information system and e-health. Many development gaps have been identified. For instance, the absence of natural e-health governance body, the absence of comprehensive national e-health strategy, the adequacy of both hard and soft infrastructure investment, and the security of health information system and e-health human workforce, to name a few. Fortunately, the current government recognizes the importance of ICT for the economy and social development of the country. This includes the ICT for health or e-health. The government is implementing several reform initiatives and projects under the digital economy policy. The digital economy policy will lay out digital infrastructure, including hard infrastructure, soft infrastructure, and service infrastructure to support and boost the country economic growth and social change. In health sector, health information system and e-health related program and projects are also initiated. One of the recent development is the establishment of the Healthcare Information System Standard and Processing Administration of or HISPA, the organization that serves as the National Healthcare Insurance Data Clearinghouse and National Health Information Standard and Interoperability Agency. The HISPA is the National Center mechanism that will harmonize health insurance reimbursing system of the country three major government-owned health insurance system through the standardization, data processing, and healthcare data. We realize that we have a lot of things to do to achieve effective natural health information system and e-health. We also realize that we will succeed more when we work with and learn from other country experience. AHIN is a good example of network where health IT professionals from Asia Pacific countries working and learning together to develop natural health information system and e-health. Allow me to thank organizer, the expert for your effort and on party involved in organizing this meeting. I also thank everyone here for participating and bringing your passion and experience to our meeting. I look forward to the remainder of the meeting, and I believe that the outcome of this unique and the diversity of experience within countries will help guide the way as we move to our road toward achieving UHCICT ICT together. In conclusion, I would like to wish you on a very fruitful meeting and enjoy neighbor stay in Bangkok. Again, a very warm welcome to all of you. Thank you for your attention.
Thank you, Dr. Tiem. Before we go to the first presentation, in the spirit of AHIN, where our motto is friends helping friends. So it would be good to very quickly just go around the table. Please introduce yourself and your country that you're representing, and we can go to the next person. Yes, please start. Thailand.
Hello, I'm Susan Ross. I'm from the Asian Development Bank, and we are very happy to collaborate with AHIN and WHO on this very important topic, advancing health in Asia Pacific.
Hi, good morning, everyone. I'm Mark Landry with WHO in the Western Pacific Regional Office, the eHealth focal point.
Yeah, good morning. I'm Frank Paulin from the country office Nepal.
Yeah, good morning. I'm from Kenya. This is exciting because we had an e-health strategy which we never implemented. So I'm happy to be here. Thank you.
Good morning, everyone. My name is Arimi Mitsunanga. I came from JICA in Japan. Thank you.
Good morning. I'm Wen Kai Li. I just left USCDC, joined China Medical Beijing office this month.
Good morning. I'm Mugu. I'm working as a board member and secretary of Mekong Business Disease Surveillance based in Bangkok. Thank you.
Good morning. My name is Rhea Bright. I'm from USAID headquarters in Washington, D.C. in the Office of Health Systems.
Good morning. My name is Nunik. I'm from National Institute of Health Research and Development, Ministry of Health in Indonesia. Thank you.
Good morning, everybody. My name is Nguyễn Đăng Vững, a medical doctor, and I'm from Vietnam. Hanoi Medical University. I also work for Mekong Basin Disease Surveillance Foundation, like Dr. Mo. Thank you very much.
Dr. Nipit Pirawet, Thai Medical Informatics Association.
Morning, Dr. Achit Angkadon from Mahidol University and Thai Medical Informatics Association.
Hello, my name is Unya Paripat. I come from Ramathipudi Hospital from Bangkok.
Morning, I'm Olalak. I'm also from Mahidol University.
Hello, everyone. I'm Don Prisno. I'm Associate Professor of Public Health from Shiyan Jiaotong Liverpool University in China.
Good morning. I'm Kanokwan Saechang. I'm working at Bioinformatics and Data Management Unit at Siriraj Hospital.
morning. I'm Prapat Suryapon. I'm certified topograph enterprise architect supported by AHIN.
Good morning. I'm Dr. Rita Kusriasuti from Indonesia. I just left the Ministry of Health Indonesia because due to the retirement. Now I work in UNDP Jakarta to support the universal health coverage and national security system in Indonesia. Thank you.
Good morning. I'm from the Philippines. I'm Manuel Dairit. I'm the Dean of the Ateneo School of Medicine and Public Health.
Good morning, Laura Terrell, UNICEF East Asia Pacific Regional Office, and I work in ICT for program and system strengthening.
Good morning, everyone. I'm Atul Dal, working with WHO Nepal office. Thank you.
Good morning. I'm Enda, medical doctor. I'm working as a trainer in Ministry of Health, Republic of Indonesia, board for Human Resources, Center for Development and Training. Now we are developing training about universal health coverage for all of us.
Good morning. My name is Santa Madhav Fester. I am working with Ministry of Health and Population, Nepal.
Good morning. I'm Dr. Kate Milenko from InterHealth International, and we champion open source software, IT software, and our IRIS database has been used to manage over 1 million health workers in 20 countries. And by eliminating proprietary fees, we have saved governments over $200 million.
Good morning. I'm Suchitra from Mahidol University.
Good morning. I'm Jolene Misang. I'm from Mahidol University.
Good morning. My name is Krishnavun Pat from Mahidol University.
Good morning, everyone. I'm Kane Sabutanon from Health System Research Institute.
Good morning. I'm Rina Promprasad. I'm a pharmacist from Government Hospital, Bangkok, Thailand.
Good morning. I'm Piangathai Inkan. I'm from the National Health Security Office, Thailand.
Good morning. I'm Dr. Sarana Lapunsi. I'm from Mahidol University, and we offer master and diploma programs in biomedical and health informatics.
Good morning. I'm Dr. Ding Ke from Ministry of Health. Nice to meet you all. I'm here to learn from all of you about the importance of IT governance, since given Myanmar is in our very fast-moving transition towards new developed country. Thank you very much.
Good morning. I'm Ruben John Basa from the Philippine Health Insurance Corporation, PhilHealth.
Good morning. I am Win Mintit from AHIN. I'm working as AHIN Satellite Secretariat in Thailand.
Good morning. My name is Tisupa Pilek. I work for AHIN and also Thai Health Information Standards Development Center.
Good morning. My name is Grace. I am working for the Philippine eHealth Program Management Office under Dr. Marcelo.
Good morning. I'm Manchana Phonthongmat from Thai Health Information Development Center and also AHIN.
We have two more over here.
Good morning. I'm Dr. Tema Mong, and I'm from the Department of Medical Research, Luan Myanmar, from Myanmar.
Good morning. I'm Dr. Sula Thomni, Special Officer from Department of Medical Research from Myanmar.
My name is Maureen from MBTS. I'm working as an ICT.
Thank you. Wow. Already, okay. Wow, we have a very diverse group of participants today, and what we'd like to start out is basically in an AHIN meeting, everyone is a teacher and everyone is a student. We're here to learn from each other, so make sure you ask questions from the speakers. Speaking of which, our first speaker will talk about the importance of learning networks for national health capacity building and emerging trends in health IT, civil registration, and vital statistics. I asked him to leave about 5 to 10 minutes so that we can ask him questions. From the World Health Organization, Western Pacific Regional Office, Mr. Mark Landry. A big hand, please.
Thank you, Alvin. Thank you, Bunchai. It's a real pleasure, as always, to be with this
Friends Helping Friends community. And I wanted to start off because this is kind of an early discussion today with our program for the whole day, speaking about some very common principles or issues and try to speak very plainly, but then also recognize some of the technical matters as well that we can appreciate, particularly since some of the members in the audience here today are very senior level officials that we hope we can really resonate and understand the importance of appropriate use of information and communication technology. So with that, I start with a comic. When we think about ICT, and if we compare this to the two thoughts by these two people, we have to be on the same page and have the same idea of what it is we're talking about. If we don't have that same shared idea of how and why and what ICT can and will be used for, we're going to fail from the beginning. So keep this picture and this in the back of your mind. So there's some key messages I want to deliver in about 15 or 20 minutes today. One, of course, is that we're all here because we understand and have a belief that ICT is an enabler to better measuring and achieving of universal health coverage. We also recognize as members of this community of the AG Health Information Network that it really does take a lot of collaboration by champions that are trying every day to improve the use of ICT in your countries, as well as development partners and implementing partners, technical agencies, and so forth. And it's really through partnerships that we need to rely on to optimize these limited resources for e-health. And then lastly, which is really the focus, I think, of the dialogue today, is how do we effectively build capacity? And I'll elaborate a little bit on that as well. So in last month, we had a flagship conference hosted by the Asian Development Bank in Manila, a conference on measuring and achieving universal health coverage with ICT. But in reality, we have to start with the questions. Putting the IT aside, what are some significant issues that are facing ministers of health, as well as senior management in these health systems? So for example, in the Philippines, particularly interested in where are quality services being delivered effectively and efficiently, and how to expand that coverage. In Cambodia right now, they're preparing to develop their Health Strategic Plan 3 starting in 2016, and so they want to determine how best to monitor both the strategy and its implementation. And then in Laos, PDR, through a number of surveys and research performed in that country, have recognized that addressing maternal child health is still a significant issue, reaching the underserved, hard-to-reach populations. And so how does their health sector reform help achieve better health for women and children? One way that this has been catalyzed to understand how the health systems perform to address these different issues is the use of an innovative technique of exercising that data and developing what we call a dashboard. In the Philippines, this is an effective measure of tracking performance. And if you look at the array of indicators, and without going into that list, but the point here is that it's a short list of very, very specific measures of both financial risk protection, the quality of the service being delivered, its coverage, and infrastructure improvements. And by focusing on this core set, the minister or the Secretary of Health is better equipped and able to make key decisions more often than on an annual basis, but more appropriately on even a monthly or quarterly basis. The Cambodia experience has been to see how much information they can exercise from their routine health information systems, building off of their customized solution to visualize indicators from their facility-based reporting, and aligning those indicators with those that are recommended from the global monitoring framework for universal health coverage. as well as thinking about how to integrate data from other sources in the future. In Laos, as I mentioned, their focus is on how well are services being delivered to support women's and children's health. Are women getting the prescribed good practice of 4 antenatal care visits before birth? Are those births attended by midwives or other skilled birth attendants? How can they actually measure and monitor this information at the subnational level? And you can see with some of the color coding, some of the priority areas are identified through the use of these innovative dashboards. But this is just one dimension, looking at the use of information and communication technology for measuring and evaluating our health system performance. This slide just tries to illustrate there are still a number of issues, and many of these pain points that you may recognize with your own health information and use of e-health solutions in your countries exist around fragmentation, a lot of data not being used, the limited skill sets and capacity to improve the quality, analysis, and use of that data, lack of appropriate legislation, limited use of data standards, some opportunities for improving the communications of that information, and understanding that significant investments in ICT are still needed. And this is the reality that much of the health information and e-health practitioners in the ministries of health are either undervalued or lack many of the skills necessary to perform optimally in their positions. So the WHO has on the record 2 resolutions in e-health. One from 2005, just setting a direction to encourage member states or countries to develop and implement e-health strategies. And then more recently in 2013, to take a standards-based approach and implement appropriate health data standards and ICT standards to ensure that data can be shared and used more efficiently. Within WHO, we have a cascade of platforms to support countries. The global and guidelines to the regional level, where as the platform that I sit in Manila for the West region, providing technical support, working through collaborations, supporting networks like AHIN for knowledge sharing and learning, training and certifications, and of course coordination. And then of course at the national level, that really most important and most significant, where e-health capacity strengthening needs and should happen. And there's a number of tools and priorities that have been set with tools available, rather, to help address these. These are some of the shared priorities that we have seen emerge in our Asia-Pacific region. Better advocacy and leadership in governance, including working across other sectors. Strengthening both institutions as well as individuals with better capacity, focusing on data sharing and interoperability. What does it take to scale and sustain and use best practices? And then ultimately, maximizing the quality, analysis, and use of health information for decision-making at the point of service delivery, all the way up to health sector policy strategies and planning. This is a somewhat busy slide, but it's to explain or show that we have two different dimensions at play when we talk about the use of ICT for health or e-health. From the bottom to the top, we have an emerging ICT environment, right? There are investments being made in all the countries in the region, particularly in mobile health, for example. A lot of broadband and internet accessibility is increasing. The use of cellular phones is everywhere. And then we have, from the left to the right, an emerging enabling environment within the health sector. With these different dots, you can see that depending on your country, you might find yourself still experimenting or working with projects that might be on a pilot basis, working towards developing and building up some of those solutions, all the way up to scaling and mainstreaming e-health as part of just regular day. Components the consultations and understanding that we all share, that what does it take to implement effective I've discussed much of the details are developed. A classic planning approach. What are the priority actions to be addressed, and then how to identify those activities in more around successful. It's great at failures as much, and then talk about it. And I think that's where the power of AHIN is greatest. So I wanted to just maybe try to take another way of looking at a complex issue in e-health using a simplified approach. Why data standards and data sharing matter at the point of service delivery. Look at who did what to when and where. In English, it's a very complex question, right? But let's unpack a little bit here. So that we need IDs for those individuals providing services. Who, of course, is the patient, and we need a patient registry identified with, for each and every individual, so that when you receive services in a clinic, and then maybe the health information system approach in this country, for example. And then, of course, where are these services delivered? We rely on a facility registry. Now, when we describe what diagnoses or procedures were implemented, this is where we have to think about what are the standards. Here in Thailand, for example, they're committed to LOINC, they're committed to SNOMED CT. There are an array of standards available, and it's important that all countries declare what standards to use and how to implement them effectively. Ultimately, we want to get to a point where we can have a shared health record. That's where the time stamp comes into play. When are these services delivered? So that the next time we need to order an X-ray, we don't have to get a new order, but we can use the scan previously, for example. But having a shared health record helps us identify and track the longitudinal patient monitoring. And then finally, we work towards developing a health information exchange so that we can have openness and shareability of that record. I'm going to work through this next few slides rather quickly now because I think all of you are aware of the AG Health Information Network. There is a similar network in the Pacific as well, but it's through these platforms that really help create success. And here's how, and we'll talk more about this today, later on the program, is what are some of the steps to build national e-health capacity, and what are some of the ways to operationalize that e-health strategy itself, understanding what skills are needed for developing good governance, and ensuring that at the institutional level that there is a framework for the e-health governance itself, how to scale and sustain those investments. There's a good certification programs, but just understanding that they're out there. Is the fourth step. Learning how to manage our ICT investments effectively with from the IT sector. Certifications and tools for that. Including IT to share, and some of you have seen this before, but it's just to show that even in our role as WHO or with an array of development partners, no has inspiration and as well as having appropriate access to the informatics community where those important data standards reside. And implementing those, and then aligning with additional communities of practice and creating networks of networks. But it's through this entire community of both people and processes and shared principles around reuse of ICT, around openness and transparency. This together is how WHO believes and supports the AG Health Information Network and other communities of practice as the ideal platform to support countries, taking a regional approach for country-level impacts in e-health. Thank you very much. Would probably be able to answer questions as well as an introductory.
Thank you, Mark. I think we have time for one or two questions. Usually when we have a kind of to discuss whatever topic involving the health IT or e-health. So please, if you have any question, and thank you for Mark for showing us the vision of the WHO or the direction that the WHO giving to countries about developing the health information system and e-health around the world. Okay, please.
Thank you, Mark. One of the things that we're going to do in Nepal is And we were in that discussion, scope of e-health strategy, basically how it needs. And what we have come out with is similar time is our National Health Program 3rd is getting developed. And the e-health strategy needs to complement and talk about technology use. But what we were not clear on whether the e-health scope of e-health strategy would also involve monitoring and evaluation and also data quality and data use and other scope of it, basically, to contribute. One of the outcome in national health strategy is best use of evidence for program planning. So how do you suggest, that we go on these kind of issues? That's
Sure, thank you for that question. And if I recall from the introductions, you're with WHO in the Nepal office, correct? Yes. So I think there is a lot of overlap between e-health and health information systems. And it's really for ministries of health to declare the boundaries of both or refer to them as one and the same. But just as you suggest, and I think we really want to support ensuring that an e-health strategy or a health information system strategy is not developed in isolation, but is actually a part of the national health sector strategy or implementation plan. And that's essential. But as I said, kind of declaring what those boundaries are so that everybody who uses that terminology, which of course won't be in English, it'll be in the local language, recognizes the boundaries and then decides what's in, what's out. We didn't allude to much in this discussion already, but when we talk about e-health, we talk about e-learning and telemedicine and different types of use of e-health, which can really push out the boundaries as well.
Okay. Thank you, Mark. And before I proceed to another presentation by my co-chair, I would like to introduce the document in the back. Actually, these are all the documents that we got along the way that when we worked at the as the network. Unfortunately, we don't have the National e-health strategy toolkit books distributed now, but you will easily download it from. You can Google, use the National e-health strategy toolkit. It all and it's a good document. The red one is the document talking about one of the very important and very difficult issue is the how the countries develop the identifier, the citizen identifier or the provider identifier. This is the I think HEDFAR and UNAIDS help sponsor to develop this document. Another one is the document that provided by one of the network that partner with us, the Joint Learning Network. This document is talking about standard and interoperabilities. And with the leaflet, you can see the sample of the newsletter of the AHIN that we publish every quarter about the activity of AHIN, and also some issue that we are talking about the capacity buildings and the ICT and the sample of the COVID and TOGAF, the technical part. So this is all the document for you to go home and you can look at as you want. But we will not discuss this in detail. It's just for you to go for your information that you can learn what we have done and what we do in the network. So the next presentation will be my dear co-chair, Dr. Alvin Maciero. He is the National e-health program management officers, the team leader of the Philippines. And he is also the professor of health informatics at the University of Philippines. And importantly, he is the co-chair of the Asian e-health information network. Please.
Thank you, Dr. Bunchai. I'm not very good with PowerPoint presentations, so I always use black and white on my slides. But the title of my presentation is coming through the list of challenges that Mark already listed. Also, some of the things that we have learned from each other as e-health practitioners in each country. First, some declarations of some disclosures. I'm an associate professor of surgery at the University of the Philippines, Manila. It's a state university. Right now, I am the team leader of the National eHealth Program Management Office. Gracie is one of our project officers there. I'm the co-chair of AHIN. I'm certified in GEIT and Enterprise Architecture, but what I wanted to show, which is not appearing, is that I don't have stocks or financial interests in any of these. UHCICT, Information Systems Audit and Control Association, or TOGAF, or the Open Group Architecture Framework. I think I need to say these things because I'm going to be mentioning them in my presentations. I have two objectives in the next 15 minutes. Share the insights we have learned from each other, Dr. Bunchai, I Sain from Myanmar, Dr. Sambat from Cambodia, over the past 3 years on the challenges faced by the countries with their national e-health programs. Second is to propose a framework for designing a capacity building program to address these challenges. So just very quickly, the WHO definition of e-health is the use of information and communications technologies for health. So very simple. And Mark already mentioned the two documents from the WHO officially recognizing e-health. But what makes e-health difficult? So I had the benefit of working with several ministers of health in the Philippines. Of course, Dean Manuel Dairit is our former Minister of Health in the Philippines. Secretary Ona is just the recent former Secretary of Health. And at their level, and that exposure to these ministers allowed me to see their perspective. Their perspective is, just make it happen, Alvin. What resources do you need? Just make it happen. But the health system is very complex. There are many stakeholders. There are many sectors involved in an e-health system. Can you imagine in the health system, there are so many stakeholders, the pharmaceutical industry, the doctors, the nurses, the government officials. Then you're putting in E or IT or electronic. So you need to bring in the IT professionals. Then you bring in the financing, the social protection, the telecommunications, and of course the private companies. The complexity just increases and increases. Okay? Each sector in a national e-health program has a part to perform. And if they do not perform that part, if it is not clear to them what that part is, the whole system will crumble down. And very clearly, in e-health, the health sector is the leader, and the other sectors are supporting actively. So it's very difficult because it's multi-component, multi-stakeholder. Healthcare by itself, just taking care of a patient, just taking care of a community health is very, very complex. IT is very complex. You need to know how many RPMs your hard drive, what are the competencies of your systems administrator, how many servers to buy, what is the cloud system. These things are beyond the knowledge of a minister of health. But those are the things that we are asking him to make decisions on. So merging very complex domains like health and IT, if you do not do it properly, it can actually increase your problems. But if you do it correctly, the IT component, the organizing potential of information technology can actually help manage the complexity of the healthcare system. Unfortunately, IT is not taught in medical school. They teach us how to take care of patients, bring them back to their wellness. And there are very few people who can merge these two domains, health and IT. There are already few, and rarer are those who have experience doing this at national scale. Actually, I don't think there was any up to this point. So these are the insights we get from the many conferences that we've had for the past 3 years. So these are comments. I will not name names, but these are from IT managers. They're very frustrated because they know that they can really help improve the healthcare system. But the top level decision makers or the ministers do not give clear instructions that yes, we should use ICT for healthcare. And yes, here are the resources that you need to use ICT in healthcare. Decision makers do not know how they should govern over e-health for national implementation. There are no adequate resources to support their e-health. Okay? They just say, okay, let's use information technology. But then after that, there are really no clear signals on what are the indicators or what benefits they expect from a national e-health program. Let's hear it from the other side, because I also have access to the ministers and vice ministers. From their perspective, well, you know, these IT managers, they don't know how to tell us what we need. They're the IT people. They should know what we need in terms of information technology. Okay? They don't know how to engage us. We are very busy. We are attending a lot of meetings. So if they need to teach us about what is an RPM, what is cloud, I don't have time for that. Government does not know how to commission the parts of an e-health system. An e-health system, you'll have a data center, you'll have servers, you'll have CPU, hard drives, network, cloud, systems administrators. These are just beyond the problems of a minister of health. The problem is we don't have enough doctors, we don't have enough nurses. Now you're telling me we don't have enough systems administrators? So it can be very, very complex for a minister of health. Now the last one is, we are spending so much already on our IT budget, but I don't have email working in my office. Okay. So these are very, very real frustrations also coming from both sides of the governance, which is the minister board level, and the management, which are the IT people running the e-health program. John Basa will be very, very familiar with this problem. So over the past 3 years, the members have been asking, can we help each other? Can we have capacity building for our decision makers so that they will know how to govern and give clear instructions to everyone down the line? Okay. In consideration that they are very busy, they do not have time to learn about IT anymore. Okay, so that's the challenge. Second, after the decision makers know how to govern, they cannot do all of the management and operations. They need to pass that down. So they need to pass it down to a group called planners. And these planners get the instructions from the decision makers, and then they design the architecture or the blueprint of how we will now use information technology so that the needs or the expectations of the governance are met by our IT system. Then, from that blueprint, you give it now to the developers. These are the IT people. Looking at the blueprint, like your house, the blueprint of your house, they will know how much bags of cement to buy, how many nails, how many planks of wood to buy, because they have a blueprint. So now they will know how many servers we need, how many hard drives, how many people, expert people we will hire. Then, government cannot do. We were just frustrated. But with AHIN, I met Dr. Bunchay, I met other people from other countries. We shared the same problems, and we were solving them in pockets of solutions. But then when we put together our experiences, we saw that we were getting snapshots, and then we were slowly completing the big picture. And this was, so far right now, the big picture to us. It's IT governance. IT governance, I think you have a copy in your bag right now. Ignore everything in the blue part. Ignore everything in the blue part because the 5 boxes at the top is basically what I showed our former Minister of Health. Of course, he was very frustrated with the IT system. So basically, he said, what do we need to do to make our e-health system successful? And I said, well, sir, we need to have a framework, a way for you to find out whether your expected benefits are actually trickling down to the IT operations. And you can do this 2 ways. You can do it without a framework, meaning business as usual, as we are doing things right now, and you are very frustrated, or we can use an IT governance framework. So I actually brought him to the IT governance framework. And so the minister said, I don't think that's a question, Alvin. We should use an IT governance framework. And there are only 2 IT governance frameworks right now. There's COVID-5 and ISO 38500. It's a British standard that became an ISO standard. I studied both, and the British standard is $100 and COVID-5 is for free. So I just downloaded this, and of course I studied it, and I got certified on it, and I showed it to the secretary. And I told him, sir, you only need actually to do 5 things. Number 1, you need to tell everyone down the line that we will use an IT governance framework. Because if you don't say that, then everyone will just do their own stuff without linking back to you. So that's box number 1. Second, you need to clearly tell them what benefits you expect from the e-health system. And he said, oh, I know. I want the e-health system to help decrease maternal mortality to 52 per 100,000 live births, which is MDG 5. I want e-health to help me increase financial risk protection to at least 90% of our citizens. I want e-health to tell me what is the status of our investment on health facilities. And number 4, I want IT used in all public health facilities. Nothing technical there. Everything within the Minister of Health's desires. Of course, the Minister of Health is the alter ego of the Filipino people. So with those 4 benefits, we then asked him, then what risks are acceptable to you? And he said, well, we have to respect the privacy of these patients. We have to make sure that the system will not increase the risk of people dying. So you need to have good systems that will not have wrong information that are given to the doctors, things like that. The 4th box is, will you, as the board level, together with the Minister of ICT and the Philippine Health Insurance Corporation, will you provide resources so that we can achieve these 4 benefits, if you like? And he said, yes. So he called the Minister of ICT, he called the President and CIO of the Philippine Health Insurance Corporation, and they said, this is the 4 goals. Do you share my goals? They said, yes. Then let's put in our resources on the table. As the Minister of Health, we will buy the computers for the clinics. As PhilHealth, you give them the reimbursement for their services so that they can now buy their own computers and they can hire their own people. And then as ICT, can we use your data center, the Government National Data Center, for our national system? And so all of these stakeholders came together, gathered by the Minister of Health. They agreed on the goals, the 4 benefits, and then they put their resources on the table. And then the last one is that there should be stakeholder transparency, which is easy. Just bring all the people together and informing them of the status of the project. And that's basically what IT governance starts from. It starts from the governance side at the top, And then those 5 boxes trickle down to the blue part, and then these are the parts that you give to the planners, the developers, and so the ministers take care of the top part, the evaluate, direct, and monitor. The planners, they get the instructions from the ministers, and then they align, plan, and organize. Then they come up with a blueprint or the architecture. That architecture is passed to the developers, and they will now build, acquire, and implement based on the blueprint. And then once it is built, they give it now to the IT operations, which can be run by the ministry or they can outsource it to the private sector. Then over here, going back to the planners will now monitor whether the people who developed it and the people who are operating it are actually doing it the right way, and they report back to the ministers. So in the Philippines, which I will discuss more in detail later on, the ministers meet quarterly, and the planners, developers meet at least twice a month. And therefore, we organize all of these needs for capacity building in what we call the AHIN National eHealth Capacity Roadmap, which starts with strategy. You need to have a strategy. And so once you have a strategy, then you start building capacity for IT governance, and we're using the COVID-5 framework for that. Then inside, there should be a group of people who know how to write up an eHealth blueprint. So I'm happy to see Prapat here, who is one of our alumni. He's a certified enterprise architect. By the way, because of the support of AHIN, we now have 9 enterprise architects in Asia. And according to TOGA, this is one of the biggest sectors with enterprise architects. Then we have for developers, they need to know about the standards that are already available. Don't reinvent the wheel if the wheel is already invented. The more you reuse the standard, the more powerful it becomes. And then there's program management and IT operations, or ITIL, for the IT operations people. In the afternoon session, we invite you to join our discussions on how your country can partake, sorry for the grammar error, AHIN's eHealth Capacity Roadmap. And I now open the floor for comments, questions from the audience. Or if you can also share some of the challenges that you face in your country, if you resonate or you also have some things that we missed out from Mark's presentation and mine when it comes to the use of IT in healthcare. So the floor is now open for any suggestions, comments, and ideas. Thank you. I will facilitate and also monitor our time. Do we still have time, Dr. Bunchay? Yes.
I just have one comment that when countries are designing their architecture or choosing software, to consider both and gone.
Accept it. If it doesn't fit your blueprint, tell them how it does not fit the blueprint, because these people will comply. They will tweak their system so that it maps into an architecture. However, if there is no blueprint, then it's everyone for everyone. Because, well, the country doesn't have a blueprint, so I think my solution is the best solution for you. Yes, sir. And then Don. You first, sir.
Yeah.
Dr. Dairit.
Thanks. Thanks, Alvin. I feel I need to respond because you alluded to me earlier.
Sorry to put pressure on
maybe
you.
I can just say that when I had the top job at the Department of Health, maybe I should have had you as my IT advisor. But at the time, we were only starting email.
Yeah.
But anyway, maybe since we're on the discussion of policymakers, maybe just to frame the discussion, I was thinking that when I was a policymaker, I was looking for a number of things. One was the reliability of the source of information. The second would be the accuracy of the information. The third would be timeliness and regularity. And I guess the fourth would be maybe an analysis and making sense of the information that I was getting. And the reason I needed to have this was, one, I needed the information for programmatic interventions, certainly for public information and managing the media, and then thirdly, for budget and investment decisions. But I guess having said that, I'm really enamored with the different people in your very complex system, these 5 levels: decision makers, planners, builders, service providers, and users. My comment really is, if you can get the decision maker and the planners together, then maybe you can begin to say, let's move towards the vision of IT governance. But what I perceive now is that when you get to the builders, the service providers, particularly the contractors, and the users, then it's chaos.
If you don't have a blueprint and a governance framework.
Even if you have a blueprint. And I guess this is what I want the discussion to be, because for example, now as dean of the medical school, I'm in touch with all of these people who are developing systems.
Yeah.
And they say, we've got an electronic medical record, and
yeah.
there are 5 others in the country who've developed theirs. How is the government going to decide what to use? And when you decide what to use, you're committed to it for a number of years or over
Correct.
the long term, right? And then, of course, there's these issues of the contractors that are involved in that, and of course, the users and the providers. So maybe a comment on that is, how do you manage the chaos at the lower levels of this pyramid that we're trying to build?
I will still go back to governance and architecture. If the governance is clear, as in who makes decisions about investments and the design, which is the top level, and then is there a blueprint? Because the blueprint, you can use the blueprint as a test. Okay, you're offering me your electronic medical record. We have a blueprint. Can we now see whether your solution actually will fit into this blueprint? The chaos will always be there because people are very intelligent and they have very nice solutions. But unless there is a blueprint, then there is no benchmark against you can actually now make decisions that, you are actually 80% compliant with the architecture, but you're not compliant at 20%. Can you go back, 1 month from now and show me that you're now 100% compliant? And you cannot say that without a blueprint. With a blueprint, you can start saying those things. It doesn't mean that the chaos will not happen, but the chaos will more or less be managed.
Maybe just a follow-up question then. In developing the blueprint then, is it a technical decision or is it a political decision?
It's a governance decision. First, that yes, we will have a national blueprint. And the blueprint will have the stamp of the top-level governance committee. Because if there is no stamp of the National E-Health Committee, they will say, that's just Alvin's architecture. There must be a better architecture here. And yes, there are many architectures and all of them can actually be right. But there's only one architecture that will have the stamp of the top-level steering committee. That's why you need governance, not just architecture. Because when you give us the 4 benefits, maternal care, UHC, health facility enhancement, and IT, you give it to Dr. Bunchay, you give it to me, we can come back to you and it won't be the exact same architecture. It might be similar, but then that small difference can spell a lot of the chaos later on. So now you need to go back to the top level and then they have to choose. Dr. Bunchay, your architecture blueprint, I think, is the best from that meets our 4 benefits. We put the stamp on you. Alvin, you help Dr. Bunchay. Fine. So now we know that we will now work with that architecture. Without the clarity coming from the top, chaos is automatic. For sure. Of course, you've all experienced this already because you get a lot of solutions from vendors, and then when you try to connect them later on, they cannot because there was no architecture in the first place when they started offering it. Can I ask Don, and then I'll call you. Thank you. Don?
Good morning. Thank you very much, Alvin. It's very good that you are now getting into fields of governance. But we very well know that governance, you have the governing group and the one who are governed. So you have the people and the ones at the top. And I noticed, we just finished a study on the use of information technology in disaster management, that most of the policymaking process are mostly top-down, simply because there's information asymmetry of the knowledge of those who are technocrats and those who are at the bottom level. Now, this becomes a problem then in making a framework of governance when it becomes a top-down approach that there's no sense of ownership of the mass population that you are actually trying to work for. In other words, the problem becomes that in the framework of governance, that this policymaking becomes a tool or instrument of, I would say, the use of the word manipulation, where policymaking is based on the thinking of those who are governing and not those who are being governed.
Correct.
For example, what we found out in disaster management, they had the information at the top, the people had no knowledge, therefore they are the ones who are making the decisions on how to do evacuation, because the people had no knowledge, they had access to information, but the processing is not. And I don't see in your framework on how those who are below should be involved. I think, therefore, my suggestion to AHIN is to have a subcommittee on ethics and also the involvement of users and also the involvement of social sciences and researchers.
Or during the afternoon, because we'll discuss the answers to your questions in the afternoon. There are actually details in the COVID framework that allows for end-user involvement. But I did not mention it anymore, but the framework actually must, because the users are stakeholders in the system, and the enterprise architecture approach requires you to approach the end users of the system and get their inputs. Yes. Yes.
Yeah, thank you, Dr. Alvin. It was a great presentation. And yeah, similar to those questions that I was just trying to place, is the users, I think users are the ones, the frontline users, basically the beneficiaries that are the patients or the population, people, and frontline users at the periphery level, the district managers. This is what we are approaching in Nepal as well, to assess them first, assess their need, and then come out to have what kind of infrastructure is needed, at least for around 5 years or 10 years period, and then come out with a blueprint. But anyway, as you have said, that follow-on the after lunch session cover that as well. So
Thank you. Dr. Bunsai?
I think now the break are available now, but before we end up this session, we would like to have this opportunity to have a group picture. Can we stand up and...
So this is challenging, Dr. Bunsai, because the group is quite big, and
so we would like you to this line row stand up, and then help us to push the chair a little bit back.
To allow people to stand at the back.
Stand at the back. So we will take the picture from there to here.
So we'll maybe about 15 chairs here. Not straight to the wall because people will stand at the back, doctor. So a little, please give space, a little, okay. And then we will ask the people on this side to please join us. Thank you. All right. We got another instruction from the photographer. I think that's has higher value in governance than my. So we will have it in front. Okay. So that's what you call. That's what you get when you hold the hardware. Yeah, we'll put one slide. We'll project one slide from AHIN, and then that's true. Can we just try it and then? No. Okay. But we need to crop the. We were asked to have come over here, so thank you for cooperating. But I don't think we can put in a lot of chairs here. Susan is going to flash on the face of the people. Maybe we can add more chairs, can it? We have more chairs there. Please, sir. Thank you. Okay. So we were surprised there were a lot of people, so we're happy. So you have to smile. I think the official camera is the one. Okay. It's gonna reflect on the. We'll just put graphics. Thank you. Thank you very much. And we'd like to invite everyone for coffee break outside. Yes. Coffee break is over there. Yes. I think that's where it is. I mean, the cutover might be, and they don't see the work.
Well, you know, the is calling out registry, then, you know, you can't have this one here, this there. It has to be. Right. Let us know if there's So, yeah, so, if you could directly. I'm also Definitely invite Carl.
say. So I will talk about a bit about the conference. Is it on?
Welcome back, and we're ready for the second part of our morning session. Let's wait for the other people to trickle in. Thank you and welcome back. For the rest of the morning, we have 2 more presentations and of course an open forum after every presentation. Our next speaker has been very instrumental and helpful in our last year's general meeting and the Conference on Measuring and Achieving UHC with ICT. She's a Senior Social Development Specialist, Regional and Sustainable Development at the Asian Development Bank, Dr. Susan Roth.
Thank you. Thank you very much. It's my pleasure to be here. I'm a passionate e-health person, although I'm not an expert as Alvin or Dr. Bonchai. But in my own personal history, I encountered, I would say, every level of ICT. I'm a medical doctor trained in Germany, and when I did my residency, Germany moved to electronic patient records and classification of diseases, and we didn't have any administrators. We had to type in everything ourselves. I worked in the Philippines in provincial health offices, and I was tallying everything in the blue books by hand, and then we had to count at the end of the month the diseases, and we all know that after counting 500 patients, you kind of are not that thorough anymore with your with your tallying. All of this, and then I joined ADB as a public health expert, and in ADB I can say we have similar problems that we have in the health sector, where we buy ICT software, it doesn't work, there's no interoperability, I travel, I have no email, etc. And I'm really passionate about efficiency gaining from ICT, and again, very passionate about ICT. So I'm very, very happy to work with this amazing team. AHIN and we at ADB hope to add value to e-health in Asia Pacific. The involvement of ADB in the last year, in particular in hosting this conference, Achieving and Measuring Universal Health Coverage with ICT, is the beginning of a longer-term strategy to support ICT investments. It will be a crucial part of our new operational plan for health, and we hope to start the dialogue with countries on what investments and what kind of loans or grants countries need to build an interoperable, efficient e-health system, which is, of course, often also connected to a larger e-governance plan. So I would like to talk a little bit about the conference. Some of you have been there, right, at the conference, I assume. Those who haven't, they missed a lot, and I hope you can join us for this year's event. The conference was unique in the aspect that it brought really together experts from Ministries of Health, from ICT, from telecommunication, from finance, from social protection, from statistics. And I think this is really also the strength ADB can bring into AHIN and the network to enable the cross-sectorial work. And that is what Alvin also emphasized, what we really need. The conference was very interactive, and we wanted to come up with concrete actions, and that's what I want to present to you today. I think very, very important is, and I like really this quote from Steve Jobs, and I will read it to you. The first rule of any technology used in a business is that automation applied to an efficient operation will magnify efficiencies. The second is that automation applied to an inefficient operation will magnify inefficiencies. And same is true, of course, for ICT and health. And we know all that our sector is not necessarily the best managed one and not necessarily the most efficient one. So that's why it's so important that we apply very simple guidelines and I would say rules to guide us through the process of implementing ICT in our countries. We really have to make sure that complex issues like ICT become simple. And I like to refer to Mark's house that we have to build. We really have to think about ICT and e-health like a house that we want to construct. And it's one thing to have the blueprint, but also really to have feedback from those who are using the house, if it works, if it's stable, and if it's fun to live there. That's an important thing. So I would like to go with you through these IC10 steps. The first one is really know your baseline, and that's something which has to be led by the countries. And what we see is that often new investments are driven by development partners, it's easy maybe for countries to take them, get them for free without really thinking, do they meet our gaps? Do we really need them? So it's important that we have analysis on hardware, software, policy, systems, capacity development, and that we know also what is the vision that we want to achieve. And that's why this regional network is so important, to see what do others have, what works, and what's our gap in achieving this vision. And you can have different visions. You can have you can aim for a Volkswagen, you can aim for a Mercedes, but important is that you know which of the two you want. The second one is get everyone on board and bring your best team. And that's something Alvin emphasized. It's really important that we bring different ministries together and that we have commitment at the highest level and that we establish interministerial committees. Of course, there has to be leadership from the Ministry of Health so that these working groups and committees really start working and that we have work plans with very clear performance targets and results. The third one is adopt, adapt, or develop tools. But the crucial message here is really look what others have and use that. Don't start developing your own systems, which you might the ones your country need. But generally, what we see in the 21st century, most things have been done already or developed, or there are other people in the world who think about the same problems. And that's what AHIN can really deliver. It's the network advantage, bringing and crowdsourcing ideas and solutions. The fourth one is, and that's so exciting, I think, since past years, that countries really commit to universal health coverage. And at the political level, it might sound just like a political commitment, yeah, universal health coverage without really then thinking through the process that is necessary. I think the message we really have to give to the decision makers and the leaders is we need integrated ICT systems. It's not possible without. And we need to link with social protection, the civil registration via statistics. We need to know who is covered, what services are covered, what services are delivered, who's doing it. And these are really still the building blocks of universal health coverage. So we need to make sure there is budget available for building integrated ICT systems. The fifth one, and I'm sure Mark can talk more about it when we have the discussion, is investing in unique ID schemes and link it with civil registration, vital statistics systems, and universal health coverage. We see that there are still lots of problems within countries to link these two systems, often because ministries don't talk to each other, or just because the challenge seems so big and large, and you have just established one database, and now thinking about merging looks like a tremendous job. But it is important to develop a roadmap for a master person index so that we know who gets what kind of services, and also, of course, that we have feedback mechanism on what happens to these people. And from a medical perspective, we need to follow the quality of our services. We know, for instance, that in some countries, more than 60% of causes of death are actually wrong. So this needs to somehow feedback on our treatment and the services we deliver. And the sixth one is build institutional readiness and skilled workforce. And this is, of course, a long process, but it needs to start already at the medical schools or at the schools of any medical professional, that working and learning with ICT becomes natural. We have an advantage that the next generation basically grows up with ICT, and is it social networks or whatsoever. So I'm sure for them, building the house of ICT is much easier to understand than it is for us. The seventh one is, and that's a very important point which lots of governments and also people are worrying about, is how safe and secure is the data. So we really need a legal and a legislative environment to ensure that the data is safe and secure. And this, of course, is important for smaller countries who can't have maybe the cloud IT in their own country and needs to be hosted by someone else or by private sector, is really what is the legislative environment. And for that, we need to develop and enact a data governance policy. But this policy is not only relevant for the health sector, it's really relevant for all of government. So we are not alone with finding solutions. We really have to be work together within the government. The eighth one is, as someone from the bank, from ADB, of course, that's one of our favorite topics, is plan for sustainable financing mechanisms from the start. What we see in many initiatives which are new is there might be initial funding coming, but then we don't really plan in national budgets to continue the financing for these initiatives or investments. So that's important. It has to be a combination of reallocating budget, raising new funds, maybe from development partners, maybe ensuring tax revenues are earmarked for certain investments, maybe taxes from private sector ICT companies, or something like this has to be discussed at the beginning. We need also to have more advocacy or more buy-in into investing in ICT now will actually pay off later. If we don't fix that ICT system or architecture at the beginning in the right way, we will run into problems later which will actually cost more. The ninth principle is we need to get concrete, and we need implementation plan with quick successes. So this is really what this interministerial committee and the working groups need to do. It's not just about the blueprint, it's really about an action plan. And this is where AHIN can help to develop a realistic action plan. And last but not least, 10th is we need to define successes, measure progress based on M&E criteria. So for whatever we do, and that's part of the action plan, we need to have a feedback mechanism, which also Alvin explained in his blueprint, which show that this e-health strategy is actually, or the e-health plan or ICT investments are actually leading to improved health outcomes, to improved service delivery, and to improve feedback mechanism for policymakers about what's going on in my health systems. And then for universal health coverage, of course, who is covered, what kind of services are covered, that these are the benefits from these e-health investments. So what we are doing together with WHO we are now, or basically it's led by WHO, but with the support of ADB, we are helping countries to develop monitoring elevation dashboards for universal health coverage, and Mark talked about it in his presentation, so that countries really have an M&E dashboard to see quickly, are in certain investments making sense, are they leading to quick successes, and that of course is an important tool to get more financing for advancing any kind of ICT investments. And with this, I'd like to finish the IC10 presentation. I show you a picture from the conference where we brought together all these experts and talked about the importance of ICT for universal health coverage. And with this, we'd like to open for questions, comments, suggestions. Thank you.
Questions or clarifications on any of the 10 items? Yes, Kate.
So I like the idea of M&E for ICT, but what would be some of the indicators, or what, do you have a framework for that M&E? Because I found if you go to M&E professionals, they know all about maternal and child mortality indicators. They don't know about ICT indicators.
Yeah, Evan is laughing. I think, there are very simple indicators like how reliable is the data, is data available, even on health outcomes, or even on how many health professionals are there, or other private sector providers listed. So it's more of data availability. I think we are still at a very early stage. In many countries, it's still about data availability, reliability of data. We see this in certain diseases like malaria, where we know we all talk about high-level aggregated data, but if we look at the provincial or at the district level, we know that the data collection is actually not very accurate. So it's really about reliability, how accurate is the data, how timely is the data collected. And maybe another indicator needs to be also the time that it takes to input this data, and of course the costs that are involved. But it depends a lot on the country and at which stage the country is in implementing e-health strategies.
But have those indicators been defined? Like, I love the idea of the availability of data, but what does that mean? I imagine if you ask each of us what it means, each of us can come up with a different definition of what it means for data to be available.
And you're right, because countries will have coming from different perspectives and different degrees of sophistication as well. Let me share the Philippine M&E. Our M&E, because our analysis was that we need to strengthen the governance. It's very simple. It's the National E-Health Steering Committee of the Ministers meeting quarterly. It's the National E-Health Technical Working Group meeting every 2 weeks. Are all the issues of the e-health technical working group resolved by consensus amongst themselves? And if not, are they able to elevate it to the steering committee in a timely manner? Because we believed that that governance cycle will get things done. And that will, we can talk about data quality and maternal care mortality, but some countries might have different priority indicators. But they would have the same process for governance, that the technical people would do their homework, meet regularly, discuss issues, and argue. They should argue because they're coming from different perspectives, but they should, in the Philippines, our agreement is that the technical working group must resolve an issue by consensus in 2 meetings, or else they need to call for a steering committee meeting, either the regular one or call for an emergency meeting. And that policy actually forces the technical working group, the different agencies, to talk together and try to solve the problem, because they don't want to call for an emergency meeting. The ministers will get mad that why don't you just fix this problem among yourselves? So far, although there are debates and arguments about how things are going to be done in much detail, the consensus approach at the technical working group actually resolves the issue within the month.
But I think the important point you're making is that there is a need to have some kind of indicators which help assess how, or they actually are the readiness indicators, right? But each country need to identify themselves what do they want to achieve, by what time, with what kind of effort. So an M&E tool would not be something that can be applied to everyone. And it might even include something like hardware or simple things like, do they have email at the district level? And we have to identify the right ones, because just counting the number of smartphones which are used so is not the not the right indicator, right? So we need experts, of course, to help with that.
But the M&E is an important thing that they should factor. Any more? Okay. Thank you, Susan. A big hand for Susan, please. Thank you very much, Susan. And she'll be here until lunchtime if you have any other questions about IC10. Our next speaker, of course, is my co-chair. But just a personal note about how I got to know Dr. Bunchai. I got to know him first by email, virtually, because we had a common friend, a Filipino, who knew him, and that Filipino friend, who is now at CDC in the US, introduced me to Dr. Bunchai by email, and we were communicating by email about the work that he has been doing. Finally, after 2 years, in June of 2011, we get to meet each other face-to-face in Manila at the Asia Pacific Health Information Systems Leadership Forum. So I think you have this experience where you know somebody virtually, and finally when you meet them face-to-face, it's like you've been like long-lost friends that you found each other already. So, of course, we call ourselves the Mutual Admiration Club. But Dr. Bunchai really has done impressive work on standardization, which we are just about to start in the Philippines. That's why this was one of the reasons we requested Mark to support AHIN, because he had something to learn from me, but I had a lot also something to learn from him. If we had to solve those problems of capacity building up ourselves, it would have been very difficult. But if we brought together people who had the same capacity building needs and solve it systematically, I think it's also cheaper for the development partners to just bring all the countries together and let them resolve those gaps. So without further ado, Dr. Bunchai.
Thank you, Mark, for very kind introduction. But AHIN is not Alvin and Bunchai. Actually, when you go back to your countries like Myanmar, Indonesia, Malaysia, you will find our working council. Actually, because we are the one that passionate on health information system and e-health, and we are really want to build our national health information system, and we know that we have limitations. We know that if we have experience from our friends, from the countries that have the similar context, similar problem, and also we learn that in literatures and also when you go to conference, they always talking about success. They want to say that I can do those and I can do this. It's really success and sell things, but they don't talk about failure. And usually 80% of IT projects is fail, are fail, and we know that. And we know that learning from failure is value, and it's much better than learning from other talking about success. And this is what our network coming to realizing. Like Mark said, that we always say that we are the network of the health professional, that we want friends to have health friends. It means that if we trust, we can talking about our failure. We can talking about don't go this way, go that way. And you can believe or not believe, but this is the lesson, the hard lesson that we learn. So don't friend tell that this is not the good path to go. So you can have more information that what kind of decision you want to go. So we starting with informal. I will talking more about the AHIN, and actually AHIN is not, like I say, it's not the IT community, only IT community, it's policy communities and the social technical community too, that are passionate on building the healthcare for the countries. And we know that health, IT or e-health is one of the very powerful tools that can build the good healthcare system. That is what underlie what we do in the network. And in your package, you will see one is about the AHIN, and I would encourage all of you to go to the website, register as the member. If you register as the member, at least you support the network, and you may not go in detail on what your manager done, but you help them, ensure them that what they do in their communities, in country or inter country will help. They are working, and it can build more passion on doing the health information system in the country. So that is what my introduction for AHIN, and I would like you, like I said before, please go to the website, register to be a member. It's free, and you don't need to do anything. When you're ready and you think that now you want some kind of the information, you can go. There's a lot of resources in our website, and also news between our network. And who we are. So we are the pool of the professional, like mostly are health informatics, IT, people who are passionate on building improved healthcare system, health financing system, or healthcare system in South and Southeast Asia. We committed to promote better use of ICT to achieve better health. So our ultimate goal is not the good IT program or a good. Ultimate goal is to achieve the better health of our nations. And as I said before, ICT, we know that e-health and ICT is very powerful in this information age. And this is the picture of our third general meeting in Manila in December, just in December. And this general meeting follow the ADB IC USC for ICT. And if you have time and go back to see the National E-Health Strategy Toolkits, you will see it very familiar with the IC10 that come up from the meeting with ADB. It's kind of the similar framework that how countries are going to build the information system that can serve for better healthcare. And we starting in 2012, and we do a lot of informal meeting, formal meeting, virtual, face-to-face meeting, and then we come up some kind of what we want to do together. And this is the strategic area that we think that can be very, the strategic point that if we do this, then we can leverage our health information system. First, we would like to build capacity on e-health, health information system, and review registration and vital statistics. The second one is that we would like to increase peer assistance and knowledge exchange and sharing through effective networking. And we know that standard and interoperability is very important, and they almost always don't visible to the policymakers. And it's very essential if you want the health information system to be pervasive, interchange. You need standard, but standard is not fancy, and it's very hard, and it's very very difficult to do. But once you do, you put it in your architecture, then things will be burgeoning and on that foundations. The third one that we know, like Alvin said, another challenge in the health information system is the governance and leadership, and we know that how we gonna strategic area that we think as a community of network we want to do together. We want to help each other to do all of this. And fortunately, we have a very good support from WHO and many developing partners. This is all sample that the partners see the value of what we do together. NORAD, right now NORAD is our major support for financing support to do all the activity that we think together and we are going to do. ADB is another one, WHO, and many of these are coming together, and some with moral support, some with financial support. But all of these are helping us to ensure that what we do is the good job, not the bad job. It's a good one. It's for our country and it's for the regional. It ensures that we come to the right track. We have what we call the implementation plan, and this is in 5 years. We do this in last 2013. You can download it in our website, and we're talking about what we are going to do in that 4 strategic area. As I say that this is the e-health strategy toolkit, which is the first collaboration between WHO and ITU. I am the academics. I have my background is I'm the physician, I'm the internist. I work as a physician for almost 15 years, and then I get into the area of health informatics. At the time that I get into the informatics, I know that ICT they want to do in the area of health, and health want to use ICT. They never go and come talk together. If you look at the previous 10 or 20 year literature, ICT, they also have the literature about how it's going to do for health, and also the health are trying to use the ICT, and it's not success. And this is the first time I think internationally that these 2 organizations realize that they cannot do alone. They have to do together. They have to think together that they come up with this kind of e-health strategy toolkit. It's kind of the guideline for the countries to build up the framework if you want the health information system and e-health to help better to build the healthcare system or build better healthcare system. Then this can be a tools that you can we can look at this, and we think that we look at this kind all the components in this strategy toolkit, and we identify what are the gap that we don't understand. We have to learn, and we use as the framework to build up the capacity roadmap. Mark already showed this. In that toolkit, they identify 7 components. And when we analyze all these 7 components, we found that what component that we are not efficient or not competent. And then we look at all these 7 components and come up with these. I think I should not explain more because Alvin already explained what behind all of these identification of how to build people to help to build the health information system. And right now we have 26 participants on online course of HL7. It's the basic HL7. We have 18 participants certified TOGAF in Manila and also the DHIS2. DHIS2 is the software for monitor and evaluation in the district level that can inform the higher level about what is going on in the district level. TOGAF you already know from Alvin, and we know from TOGAF is from the IT side, and we are now applying that kind of the methodology of architecture, the health IT system using the IT tools. This we learn from the TOGAF people that right now in AHIN is the biggest pool of TOGAF certificate in healthcare area. We are very proud of that because we are the one that are using this, and we can come together in many countries. Dr. Prapat is one from Thailand that go there. Alvin is also certified TOGAF, and many more in Malaysia. We know that our leadership need knowledge about the governance and leadership. So we look at the COVID-5, which is the IT enterprise governance or IT governance knowledge, and we can, with support from partner WHO, we able to do the workshop in Manila, in Philippines in April 2014. Gather 33 participants. And right now, in this year, we are planning to do the COVID implementation, which is the course follow the COVID Foundation in Bangkok. And we hope that we can follow up with those certified by COVID-5 Foundation. And then they will go back, help working in their country, and also can come together as the expert that can go by the group to help other countries. We also have another one that you can see, the AHIN Academies and AHIN Now. With the support of the WHO Wipro, we can have the virtual meetings, meeting room using the technology by Cisco called WebEx, which is today we also use the WebEx to broadcast the meetings. We do the webinar every 2 weeks in English, and also each countries also have their own countries AHINs that can use this virtual meeting room or conference room to teach or to learn about the health IT and e-health. And this is the statistic of how many people in each country that we already using the platform of AHIN by support by partners to come and to get people. You can see the Philippines is very high because Philippines is very active on getting people to learn from. Mongolia is another one. Another activity that we do is that we know that some country they have a conference and or knowledge exchange in the countries, and they need some kind of the opinion experience from other countries, so they can request the AHIN for support that in their country they may not have enough budget, and we can provide some budget for our friend from another country that match with the topic of them of that conference to go there, exchange, giving the experience what they have done. So this is another way that the health IT professional and professional in other can learn from other countries. And also, we hope that we are going to have be able to gather all the people who certify in these in photograph or COVID or knowledge about the standard together in for many countries and go and have a technical assistance for the country that have a specific demand and need. And we hope that we can, this is a project that we can do by helping our friends in another countries. And this is a sample of what we call the AE now. Right now we have Bangladesh, Cambodia, Thailand, and Philippines doing all at least once a month webinar, exchange knowledge. Another one is that we use the technology called UHCICT for the resource repositories. And we know that in the literatures and in journal, there sometimes it's very difficult to extract data information. Another one is that in academic database, they don't have the report. I mean the country report, the report that's not published in the journal. But we ask our countries members that if you have report, whatever you do, evaluate your health IT in the country, you want to share, then you can share. So in UHCICT, there are a lot of artifacts, not just only the report. Software, experience, are all can repository in UHCICT, and you can look at the resources, searching it, then you get the information. That information may be not in the academic database, and it can help you doing the job in the countries. And this is all the communication that we use by our network. And Hexagon is another one of the sample of what we are communicate among this. And this is all, Alvin already said that by our human capacity roadmap, we are planning to do this. And to have this possible, they also have some support from partner and also the support in the country. If the leadership in the country don't see the value of this, then you will not allow your people who work in IT to come and learn all of this. So it needs the leadership and the administrator in the very top level to understand the value of the network among the health IT professionals. I think I will not go into how we actually when we have a workshop for the training course for country, we don't we have the mechanism, and we consider by the working councils. We don't. It's not decided by me or Mark or Alvin or Susan or people, but the working council will be consulted, and then we will rank the priorities. So, and we limited every country to have at least representative in that workshop. Everyone have opportunity. Every country have the opportunity. It's not for Philippines. It's not for Malaysia. It's not for Cambodia alone. It have to be for every country in the regions. So thank you very much for your attention. But I will happy to get questions, comments. Thank you.
Questions? Comments? In the afternoon, we'll actually detail the activities for the next 2 years. So if you're interested in knowing what those will be, and what those will be, and also suggestions of some activities that you have in your minds, and ideas and suggestions, will be welcoming that. No? Just to explain why is it a lot in the Philippines, it's because there was a training that was based in the Philippines, and we maxed out the foreign participants, but we already had space for participants, so we maxed it out with the local participants, which we didn't have to pay for travel. So that's also one of the things that we do when you host an event. There's really an opportunity for the host country to bring in more of the local participants because we don't need to pay for their travel. Yes, Mark and Dr. Nirat.
I know we'll talk more about this in the afternoon, but it's full, and I think we have a number of development partners in the room right now. I think another attractive opportunity for donors and development partners, technical agencies, is just around alignment of our work plans and activities with what AHIN is doing as well. And having that kind of a discussion and working collaboratively with the Working Council and the two of you as co-chairs, I think helps eke out more value of our investments as partners. So I just wanted to put that out there, that it's not always about your work plan activities you're doing, but the alignment provides a lot of fresh opportunities for doing more with less.
Janipit.
Yes. First of all, congratulations for lots of great job done. It's really my very first time participating in AHIN's activity. Very impressive indeed. And if there's anything I can share, I'd like to make it now, because this afternoon I will not be able to be with you. I very much in management consulting now, so I think one thing that I can share is about the model that you are driving. It's always very important to have a champion driving development of something that is new to the system, and we know that the use of ICT in healthcare is really something new, and we expect to see a lot of resistance for sure, especially from the frontline professional team. And then what we heard this morning from some participants talking about the top-down approach and the bottom-up approach is something that I think maybe AHIN's like to consider some model that can be quite similar to what we want to do here in ICT field, but they also something that very similar, have to work against resistance, and have been doing quite well with another model, which I think we can surely also use apart from the model that you already set up and driving. I see it as complementary. What I'm talking about is that the hospital, the quality management field is also something that's very interesting. We know that hospital quality in the past is always the area of very sensitive, because doctors, nurses, they feel that they're professionals and they don't want any people from outside to come and criticize them or come commenting on them that they are not doing good enough. And we know that in the U.S. They have the Joint Commission driving the hospital accreditation there. And if you look at the Joint Commission model, it's actually founded by the American College of Surgeons. And a number of professional bodies like American Medical Associations and all those specialist professional bodies come together and create the Joint Commission. And because they're going to implement hospital standards and impact a lot of doctors and nurses in the frontline team. So when this initiative is driven by the professional bodies themselves, it's quite natural for the doctors and nurses in the frontline to feel that this is not some standards from really people who know nothing, just to implement something on them. So I think IT for AHIN, if you if you can bring in more professional bodies like doctors who are going to be the user of the health ICT solution or software, or the nursing association, the medical technologies associations bodies to be the endorsers or be part of AHIN movement. I think it will be very effective because they will see that they have a representative in driving what you're going to do. And it's directly linked to the user in the front line. And it's very natural because you don't have that top-down, bottom-up type thing because it's all blend in. Yeah, that is probably some of my comment on this. Thank you.
Okay, thank you very much. Actually, Dr. Nipit is our the board member of the Thai Medical Informatics Association, which we working together on this association. And thank you for the recommendation. Like I said before, AHIN it welcome everyone, and it's starting with informal network. It's still informal, so every contribution, every suggestion can be put in here. If you go to the history of AHIN, which is only 3 or 4 years, it's starting in many countries. If the people who are passionate on health information system or the people in the health Ministry of Health that work in the health IT that come together, and then they said, oh, it helped them to work by learning from another. So that's why we have working council. They are all volunteer. We are all volunteer. We don't have salary. We all volunteer. And all the money from developing partners spent on what activity that we are going to do. Because we realize that if we work, we benefit us and all benefit others. That's the motivation that we working together. That is the spirit of this network, and I hope this spirit can go on. That we can work together to build our nation, and then at the same time working with other nation, other country. Go together, not go alone.
But I really appreciate the suggestion, Dr. Nipit. While you were describing like the Joint Commission is actually a network by itself. And one of the discussions that Dr. Bunchay and I had is that sometimes other people will say, oh no, not another network that I have to be part of. And one of the things that we are actually considering is to connect the networks together so that the people, like the doctors, go through their usual trusted networks. But through that trusted network, now have a dimension on health IT or e-health through the network of networks approach. So rather than tell them, oh, you have to be with a Joint Commission and you have to be with AHIN, we can just together, talk to the Joint Commission and find out how we can work together and help them with their e-health, or how they can help us with management of hospitals. And from that perspective, the hospitals who are members of the Joint Commission can remain in the Joint Commission, but the good news or the topics of e-health and efficiencies with ICTs in healthcare in hospitals can now happen within the context of the Joint Commission network. I think the network of network approach is going to be very powerful. So thank you for that. Yes, sir.
Sorry, I may not make myself very clear. I'm talking about using the Joint Commission model, development model, how they start and become established with the participation of the medical professional communities. So I think AHIN at the moment, from what I see, is still very much people who have the technical background in health IT, not yet very much people in the front line seeing patients on a daily basis.
Yes.
Those who are, at the moment, half of them are resisting actually adoption of any health IT. They still very much like the old way. So my suggestion is that maybe we looked at the development of a joint commission in the old days when when they want to apply the system approach to hospital quality improvement, they feel they have a lot of resistance from hospital. Now they involve the professional bodies from the very beginning.
Yeah.
So using that as a driving force. And even nowadays, they become very established. They still have this type of meetings with the frontline teams all the time to fine-tune their standards and come up with a new version. So you see, they become a self-sustaining model of moving forward with hospital quality improvement without the actual top-down from the government.
Yeah.
Even the institution of medicine not have any, direct influence on the joint commission. Yeah, you see. So it's very much driven by the professional in the front line.
By the community.
Yeah. So I think if we can somehow, also apply some of that model to health IT development through AHIMS, which already have a good foundation to move further. Yeah. So I think it can be useful. Yeah.
Thank you. Yes, doctor. Yeah, sir.
No, I was just listening very intently to what the doctor was saying. I gather with the joint commission model, I gather that